to present a case of colorectal cancer on an 18-year-old male. This patient presented, this 18-year-old male presented with features of intestinal obstruction, and he came with abdominal pain as usual, and then inability to pass stool for about 2 weeks. And 2 weeks before, 7 weeks before this period, the patient had an appendicectomy performed on him. And further interrogation did not reveal any family history of any tumor of abdominal tumor or colorectal cancers. Then provisional diagnosis the surgeons gave, they came up with a diagnosis of soft tissue mass with intestinal obstruction. And they went ahead to resect the bowel segment. What we received at the pathology point, section, we had a specimen which was received in formalin solution, and then it consists of a segment of a megacolon, a very large bowel, markedly dilated colon, weighing 1,841 grams and measuring 40 centimeters in length, with 9 centimeters in the wideness diameter. In one of the segments at the one of the resection ends, it was just constricted. The lumen is almost occluded by a tumor which is situated about 10 cm from one of the margins of resection. That's and the further examination of that lesion showed 6 prominent lymph nodes, and then one of the biggest of the 6 lymph nodes measured at 2.5 centimeters. Histologically, of course, we processed the sample that we got from the specimen, and we had we had a section that showed the epithelial malignancy, which composed mainly of moderately pleomorphic cells forming tubular and nests, with evidence of invasion of the lamina propria, muscularis mucosa, and then muscular layer, the serosa, and serosa invasion. And then the tumors are arranged in small tubular structures in areas, and they are seen floating on mucin pool. That was very important. So a lot of mucin everywhere. 3 out of the 6 lymph nodes isolated contained tumor. The overall features we said, of course, was in keeping with mucinous adenocarcinoma, which of course you can as well call it mucinous carcinoma. And in terms of staging, it was at least Duke stage C. We submitted the final diagnosis at transverse, because this tumor was also got from the transverse colon anyway. It was a transverse colon resection. And our final diagnosis was mucinous carcinoma. So this is the mass, the bowel segment as we received it. This is a portion that is constricted by the tumor. And then this another view of it, the mesenteric portion of the tumor. That is when we try to cut through the bowel lumen. This is a portion. This is tumor with showing features of variegation. You can see different colors. See, there was evidence of necrosis even on gross microscopy. And that's okay. Now, further opening the bowel, this is the fecal material trying to conceal the mucosa. But of course, we washed through this to look for maybe polyps or other lesions in the bowel, throughout the bowel. There was none seen. These are the early period we tried to open a lot of fecal material. This patient had not been passing stool for a while before this surgery was performed. But one thing with this particular sample we received, the specimen we received, there was no labeling as usual. I think in the last meeting we had, I was harping on the need to continue to label. And every effort to get the surgeon proved abortive. I would have wanted to know whether this resection margin where the tumor is found is at the proximal margin or whether it's at the distal margin. But there was nothing of such stated even in the requisition paper that was sent to us. Now, this is the histology of the tumor. The histology, of course, you can see the tumor nest of cells. You can see the tubular structures. You can as well see the milieu, the mucin pool. So this tumor, if you look through, you see that the cells are, they show every evidence of malignancy. Talk of polymorphism, talk of increase in C ratio, anything hyperchromasia, anything you can think of that will make a cell, you can make it, that can make a cell, malignant. Everything is found here. You see, some are very dark, some are light, and some are big, while some are small. Then this is another large mucin pool, and then you see the tumor cells floating on this mucin pool. And then this is another mucin pool. You can see the tumor cells invading the muscular layer. This tumor is found to have passed through the submucosa, the muscle layer, and then even involving the serosa, and then of course, to the extent of getting the lymph nodes involved. So this is a closer view of the muscle layer with tumor infiltrating the muscle layer. Now, the diagnosis was mucinous adenocarcinoma, at least stage C, Duke stage C. You can as well agree with me, this is a Duke stage, and this is a more or less a modified Duke stage. Remember the initial Duke staging, we talked about A, B, C, D, where A involves the mucosa, tumor involving the mucosa alone. The B involves when the tumor has passed through the muscle layer and involving the serosa. Then you now talk of the C involving the lymph nodes, the D distant metastasis. But in 1954, Asler and Kohler came to modify this Duke stage and then broadened it into bringing the B1, B2, and all those sub sections of the Duke staging. You remember that there are other forms of staging like the TNM staging, but of course, I think I have to limit our discussion on Dukes because which makes things so easy. The C, I said, in this particular histology, I think the best diagnosis should be Duke stage C1, since out of the 6 lymph nodes isolated, 3 were involved, and the stage C1 is when 1 to 4 regional lymph nodes are involved. But it was based on what was given to us because there was no evidence, no information given to us that this patient had distant metastasis. So that was why we said at least C. With the surgeon, of course, we probably when the MRI or CT scan, whatever investigation they do, or the bone scan is done, they may be able to find out if there is any form of distant metastasis, which of course will change the staging system. Generally, the mucinous adenocarcinoma is a distinct subtype of a colorectal cancer. It's often characterized by the presence of abundant extracellular mucin. Remember that for you to make a diagnosis of mucinous adenocarcinoma, there must be at least 50% of the tumor of the mucin should account for at least 60% of the tumor volume. So it's not any case that anytime one sees a mucin, it turns to mucinous adenocarcinoma. In short, there's hardly any colorectal cancer that does not produce mucin, because one of the components of the colon naturally secretes mucin as part of their normal secretory components. Then mucinous adenocarcinoma is found to be in 10 to 20% of colorectal cancer patients, and it occurs more commonly in females, and is also found commonly in younger patients. So by this, we have to watch out on when we have female patients and when we have younger patients, just as in this case, 18-year-old male presenting with intestinal obstruction. Moreover, it's more frequently located in the proximal colon and diagnosed at an advanced stage. So then the question is that maybe by the time we mucinous adenocarcinoma found most times in present when the tumor has gone advanced. Based on its molecular context, is associated with overexpression of mucin 2 and mucin 5A proteins. These are the oncogenes. At least at the same time, it shows higher mutation rates in the fundamental genes of the RAS, MAP, and the PI3K, AKT pathways. If you remember our the RAS, MAP, they are more or less, they are oncogenes. You know, when we talk about some genes that are involved with tumor, talk about the oncogenes and the tumor suppressor genes. And then we also remember that in every cell, you know, every cell has receptors on the membrane. And then it is through those receptors that we talk about signal transduction. So the three major receptors that are found on every cell membrane include the receptors with intrinsic kinase activities, the receptors without intrinsic kinase activities, and the third one is the 7-transmembrane G-coupled receptor protein. Of course, the RAS and MAP, they operate through the 7-transmembrane G-coupled receptor protein, whereby when a ligand binds to a receptor, it leads to some conformational change, which of course will lead to activation of the downstream receptors in signal transduction. So when there is this mutation involving some of these receptors, that of course is at the center, at the epicenter of mucinous adenocarcinoma. Shows a high rate of of course, in some areas, in some research, they found that microsatellite instability is found in most cases. Than when you compare that with non-mucinous colorectal adenocarcinoma. Then they have also found that it's associated with Lynch syndrome and the CpG island methylator phenotype. The prognosis of mucinous colorectal adenocarcinoma as to that of non-mucinous colorectal adenocarcinoma is debatable. However, the majority of researchers believe the prognosis is poor. I want to, in as much as a lot of, if you go through the body of research, you see that a lot of conflicts, a lot of confusion. Some people will tell you that mucinous adenocarcinoma has, the prognosis does not differ from that of non-mucinous adenocarcinoma of the colon. Even in our environment, ordinary personal experiences, we've gathered that any patient that comes with mucinous adenocarcinoma of the colon usually goes down the drain within a short time. The prognosis is very bad. It's unlike mucinous adenocarcinoma of the breast. It's just always good for us to differentiate between the two. When you hear mucinous adenocarcinoma of the breast or mucinous carcinoma of the breast, the prognosis is usually very sweet, very good. The patient will live long, and then if you do something, if you do your own thing early, the patient will benefit from some of the chemotherapeutic or radiotherapeutic agents we may administer. The patients are usually, they do well. They usually come with low-grade tumors. But mucinous adenocarcinoma of the colon, by the time you spell Jack Robinson, probably because of the slimy nature of the mucin, it has metastasized. That's why most of them present very late. And any tumor that you find patients presenting late, of course, what else are you talking about if not that the prognosis is going to be bad? So naturally, whether some researchers are saying this or that, I personally believe that this is a very bad omen for any patient that comes with mucinous adenocarcinoma of the colon. The prognosis is very bad. I think that's the end of it. Just a short presentation. Thank you very much.
Yeah, thank you. Thank you very much. Good afternoon, good evening, everyone again. Can you all hear me? Can you all hear me? Yeah, thank you very much, Professor Okani, for the clear presentation. You've just spoken about a 18-year-old boy who had abdominal pain, was initially operated on had an initial appendectomy, then had one form of colectomy. I'm going to assume maybe a right hemicolectomy or an extended right hemicolectomy. And the the histopathology revealed mucinous adenocarcinoma. There were two things I noticed. It said it was a Duke stage C, right? The correlate of the Duke stage C would be a T4A, N1, since they were just 3 lymph nodes that were positive. T4A, N1, and MX. That will be the pathologic staging of your Duke's correlate. The only thing about this patient is, I need to say something. This is quite a common case in Nigeria. We see quite a number of we've been seeing of late, we've been seeing a number of young people having colon cancer. In quite a number of situations, they will have had an initial appendectomy because they had abdominal pain. They will have had initial appendectomy because they had abdominal pain. After they are following the abdominal pain, had an appendectomy, symptoms failed to resolve, then they now present to maybe a tertiary center, then a diagnosis will be made of colon cancer. It's quite a pathetic story, but I like to ask for questions from all the other participants. You have questions, please. Hello.
Can I ask a question?
Yeah, go ahead, sir.
Yeah. Thanks, Professor Shino, and thank you, Professor Okani, for this excellent presentation. Professor Shino just brought up something. You are talking about TNM classification, and Professor Okani was talking about the Duke's classification. And I think that's one other thing we need to do to kind of harmonize our classification system so that when we are talking, we are all singing from the same hymn sheet, because the TNM gives you more latitude, to be able to put things into cubicles, and like you were trying to put a T, for a NM, N1, N2, MX, or M1. So it's something the association also needs to have a consensus paper on, to say this is what we're going to use and this is what so that if somebody is going from Ife to Lagos or Ife to Kaduna, you are going with the same histology and everybody will, so we have a unified or uniform system of reporting.
Yes, I think we should do that. There's always this issue between the pathologist and the surgeon, because you mentioned something at the beginning that this specimen was not tagged. There's usually this dance between the surgeons and pathologists. I think we should all try and collaborate. We should all try and collaborate with our pathologists. I think Dr. Kuka has a question. Go ahead, Dr. Kuka, please.
Yes, more a comment, really. And again, I'm glad that I think it was Dr. Eguare that mentioned it. It's very important that we standard. I was actually quite surprised, I must confess, that at this meeting we're still using Duke's classification. And I will go one step further, really. Not only should we consider strongly using TNM classification, but we should also consider adopting a pro forma way of reporting pathology. Because what that does is that it provides a comprehensive report. There were so many things that I was hoping I would hear that I didn't hear. Was there any extramural venous invasion? Was there any lymphatic invasion? Were there associated polyps? You see, all of those things also matter and help with prognostication. More importantly is the issue of lymph node retrieval. Again, really, 6 lymph nodes, I must confess, because this sounds like if it's a transverse colon carcinoma, then this young man will have had an extended right hemicolectomy. Again, as a surgeon, I will have tried to help my pathologist to know that if, with an extended right hemicolectomy, there will be cecum and small bowel at one end, which indicates that that's almost certainly the proximal end. And the other end, which is near to the tumor, is the distal end. But really, we need to strive to ensure we get at least 12 lymph nodes. In this case, because this is an N2 tumor, it may not matter that much. but particularly for other lesions, where if, for example, none of the 6 lymph nodes were positive, one would not then have known whether this boy had lymph node metastases or not because of the small number of lymph nodes. So please, I think I would advise that we seriously consider TNM because it lends itself to uniformity, particularly for, with an international audience, and also the use of proforma. And there are a number of proformas that are really, really very good. I know that the people in Leeds have popularized one, which a lot of people use. So please, those are just my comments. The use of proforma for standardization of reporting, but more importantly, lymph node yield. Thank you very much.
Thank you very much. Thank you very much. I mean, that cannot be overemphasized, the need to have a proforma reporting. I think that's what my pathologists in COOUTH, that's what they do. That's what they do. And another thing we should all try and do, we should all try and collaborate with our pathologists. We should all try and tag our specimens very well, tag our specimens so there won't be any confusion between you and the pathologist when the report comes. Do you have any other questions, please?
Yeah, I just wanted to make a comment there.
Yeah,
I just want us to understand that pathologists, they are our friends. It's like rubbish in, rubbish out. If you give a pathologist rubbish information, you get rubbish results back.
Yes,
So
yes, sir.
We need to help our pathologists to help us. So to just give them a specimen and want them to guess, they are not magicians.
No,
I mean, if you don't even specify which is the distal end or the proximal end, looking at the picture of that specimen, it looks like a segmental resection because I couldn't identify cecum or terminal ileum there to tell me that this was an extended right hemicolectomy or, so, but we need to help them so that even if you do a resection and you have your apical lymph node, at least tag it and tell them this is your apical lymph node. So it just helps them and they know what they are looking for, rather than just telling them to go and dance in the dark. It's
not, essentially grouping in the dark. Yeah. Usually we're supposed to label the specimen. If you take the ileocecal artery, this is the ileocecal vessel, this is the cecum, this is the, we should do it so that we can help them. Because helping them means we're doing very well for our patient. We're the ones interacting with the patient. Because if they don't, like you rightly pointed out, you give them rubbish, they give us rubbish, and you'll be able to treat your patient effectively.
Yeah.
Go ahead, Dr. Cooker, please.
Yeah, I was just going to say that I think you misunderstood me. I did not intend to do that. What I was trying to emphasize is the fact that, with the anatomy, it can be helpful. I also usually draw, actually. I would normally in my pathology form, put diagrams in addition to not just tagging the ends, but also the high tie, so the feeding artery. I will also leave a long tie just to indicate to the pathologist. So yes, I fully agree with you that it's very important to communicate. And the best form really is to have multidisciplinary team meetings. I think that way everybody is singing from the same hymn sheet. And in places where people are still doing cancer resections, I would strongly recommend that they consider, if not a hospital-based multidisciplinary team meeting, if necessary, citywide or even regional. But communication is key. Thank you.
Thank you so much. I agree with you.
Thank you very much.
100%.
Thank you very much. I agree with you. With that, I mean, the pathologists did an extensive work. They did a number of molecular markers on the specimen. They did a number of molecular markers on the specimen. But one thing I did not get is whether they check out, whether they assessed whether the patient had Lynch syndrome or not.
Hello?
Yeah, go ahead. Yeah, thank you, Professor Okani.
No, that one is beyond the scope of what we can do here. We don't,
all right.
Just what was sent to me was just that for histology. And then let me also use the opportunity to say one or two things about the number of lymph nodes and all those stuff. In this case now, usually we know that the minimum, the cutoff point is just to get at least 12 lymph nodes. Sometimes I don't know what the surgeons do during operation. You won't even see any lymph node at all. The last, just 2 days ago, I had one case, resected segment of bowel. I searched from morning to night. I couldn't find any lymph node, even if it's a reactive one. They just went and just cut off the thing and then removed no mesentery, no nothing, you know, and brought to me. And then if I report that there is no lymph node, I don't think one has committed any crime for not seeing one. In this case, I even let me go back to the slide. Let me go back to the slide for us to see one thing. In this case now, I even took a picture of the lymph node. I don't know where is it. Why is it not moving? Yeah, that's a lymph node, the cross section of it. This one, this one, this, and then when I went through here, went through, I could only find extra 3 in my search. And then on the issue of polyps, remember, as I said, that we cut this thing open. We don't just we cut it open, washed off the fecal material, searching for polyp. A polyp is found is a gross thing. You see it with your naked eyes. It's not the thing that you have to look under the microscope. It's during the grossing process that you see a polyp. Is just growth coming just above the mucosa. So there was none, because personally I felt this child probably had multiple polyps, that one of them probably now transformed into cancer. So there was none found in this particular case. Then on the issue of looking for invasion, in the main body of the report, I think I found one vascular invasion, though not everything is stated. And then I found one vascular invasion was there. And then even the way the mucosa was involved, and then of course the lymph node, and then even the nature, the volume of a tumor within the lymph nodes, we are also involved. Then on the part of Dukes, the surgeons I work with, because they don't supply much information, I prefer to be using the Dukes classification instead of using the TNM, which of course most times you will even make mistakes trying to put in your TNM when you don't have any information at all. And I've tried my best to educate them that there is need for them to be, giving enough information for us to be able to serve the surgeons very well. But they will be quick at removing the tumor and throwing at you. And then sometimes they will even divide it into 2 and send
all
one
right,
to
Professor. Yeah, Professor Okani, there's usually this dance between surgeons and pathologists. I think we need to collaborate more. I think this session has to come to. Thank you very much for your clear presentation, clear and brief presentation. And this session has to come to an end. Thank you very much. Again, Professor Okani.
Thank you.
Yeah, thank you very much, Dr. Shinowo, Dr. Eguari, Dr. Ratulan. We are very appreciative. Our father, Dr. Puka, thank you for your contribution. Please, is Professor Bakari with us now? I know his network is fluctuating. Professor Bakari? Okay, Dr. Koroye, are you with us?
Yes, I am.
Yeah, Dr. Koroye. Dr. Koroye,
yes,
you are welcome. Do you have any announcement for the house before we shut down?
Yes, please. I have a few announcements to make. Good evening to my teachers, our international colleagues and colleagues. I want to thank the presenters, especially my friend, Professor Chukwudi Okani. We can not overemphasize the importance of giving the pathologist enough clinical information and after our surgeries, proper labeling of our specimens. Perhaps we should, more senior surgeons or personnel should take over that function. Most times it appears we leave them for personnel as low as, without any pun intended, as low as house officers to fill this clinical information in these forms. So perhaps we should take a minute or two to actually do it ourselves. And as our senior Professor Coker had said, multidisciplinary team meetings are very key. Back home here, everything seems to fall on the general surgeon's head. The general surgeon tries to think about his own job in addition to the radiologists, the pathologists, and even the radiotherapists most times. So this forum, which encompasses a lot of people from different specialties, is very good, so that we can see how we can do MDTs, even if we don't have the correct complement of staff in our hospitals. We can do it at a state or even a regional level, as a Prof had mentioned. So I want to thank the presenters and the contributors and moderators for this. By way of announcements, we have just completed our registration with the Corporate Affairs Commission, and we are in the process of opening a society account. And we know that for a society to thrive, finances are involved. So within the next few weeks, we'll be working out modalities for payment of dues by our members. Also, the maiden study of our society has been made public to all of us. It's I reposted it on our WhatsApp group, and the title is "The Practice and Pattern of Neoadjuvant Chemotherapy for Locally Advanced Colon Cancer." I have personally filled the questionnaire, and it doesn't take much time. So I want to urge all of us to make out time to partake in the study. Our next meeting will be on the 24th of April, 2022. And the journal review will be taken by Dr. Nathan Ekwo. He's a senior registrar in general surgery in the University of Nigeria Teaching Hospital in Enugu. The case presentation will be, there will be two case presentations. The first one will be by our members from FETA, Federal Teaching Hospital, Abakaliki, while the second one will be taken by our members from Chevron Clinic, Bagada in Lagos. I also want to urge us to continue to use the WhatsApp group for robust deliberations, discussions, especially around cases. We don't necessarily need to wait for the statutory monthly meetings. We can always use the WhatsApp groups, especially for cases that need a little bit of urgency. So on that note, I think I'll hand over to the president so that he can formally close this meeting. Thank you.
Yeah, thank you, Dr. Okoroye. Let me remind us that the meetings are recorded, and we should be able to view recorded meetings on our YouTube channel. You can check our YouTube channel. Also, please, we sent a link to the group. So please, we urge everybody to join our Facebook page so that we can be having some activities going on the Facebook page too. I will still report the link again on the WhatsApp group, both the YouTube link, the LinkedIn, and the Facebook page. Before I close, I want to appreciate the presence of our Dr. Professor Ugu and others that I may not be able to mention because of time. And I want to please call on Dr. Augustine Rotulam to help us pass a vote of thanks while he closes the meeting.
Nice. Thank you very much. Am I muted? No, I think I'm. Okay. Yeah, it's been a big, very great meeting as usual, and I'm happy about that. We all know many great professors joining and also non-professors. Very interesting. And I think the best thing, what we have noted now is that the best way to solve a problem is knowing that that problem exists. So we have noted now, we've noted the discrepancy between us and our pathologist. And also, we need much more information regarding what we need, what we want to know. We have to feed them with information, as we've correctly said. So to that, what I want us to know is that we know that this problem exists. So we are here to solve it. That is why this group, this society is formed. And we are happy it is formed, it has been formed. So I'm happy about that. Once we have noted we have a problem to solve, let us sit back. And as I sent a private message to Dr. Dejmo, we'll discuss during the next week, because we have to find out really what are the colorectal problems, the real problem. It's true, we have cancers and so on, but let us begin to tackle also some other colorectal problems that are prevalent in Nigeria. So by next week, we should be mapping out. I think I have not informed Dr. Guare, but I'll get in contact with him next week. We have to begin to sort, to define places in Nigeria where we can start studies to know exactly what is happening in Nigeria as far as colorectal diseases are concerned. And that's Dr. Guare's comment also to help in training our surgeons, our endoscopists, is really a good, very good one. So I'm happy we are all here to do good to our country. So thank you very much.
Thank you, sir. And I want to appreciate everybody, especially the presenters, our international partners, Professor Gino and the other professor from Italy. We appreciate your presence and support for this society. I thank everybody that has made it a point to attend our monthly clinical meetings. And I wish you all a happy night's rest. Thank you for coming and good night.
Thank you.
Thank you and bye-bye.
Thank you.
Thank you.
Thank you.
Thank you, bye.
Thank you, sir.
Unmute yourselves.
Thank you, sirs.
Good night, everybody.